I found that there are a lot of new knowledge in it and a lot of points which I could bring it to in this talk. If you see this left-hand corner, this picture, this is a picture of various portals that was given to us in earlier books as well as texts. You had only one anteromedial portal, but now making the anteromedial portal is an art itself. We'll see that in a minute. So you have to make the portal such a way that you can make a diagnosis, especially the blind areas, as well as perform the surgery. In a place like abdomen, which you can distend or inflate it, and you can easily maneuver it. Here, it's a potential space, so you have to apply valgus varus stress and perform the surgery different areas. So portals play a very important role. If you see this picture, this anterolateral portal, one thumb breadth above, just lateral to the patellar tendon. That's a standard viewing portal. But that itself could be different, especially when you have intact ACL and you want to do a PCL reconstruction, you have to go slightly higher. The anteromedial portal, which traditionally is said as the same line as anterolateral portal, a centimeter medial to the patellar tendon, could vary a lot depending on what you're going to be performing. As we saw just now, when a lot of changes have taken place with transportal ACL reconstruction. Femoral tunnel making is difficult, it has to be precise, it has to be critical, and you have to make a far anteromedial portal. I make one single portal which is in between the far anteromedial portal and the traditional AM portal, and there are so many other ways of doing it. If you make an anterolateral portal, the anteromedial portal can be closer to the patellar tendon and slightly higher, and that could be your viewing portal. A lot of surgeons use that as a viewing portal. Some surgeons even go as a trans tendon, patellar tendon portal to view the femoral condylar notch for the femoral tunnel and make accessory or far medial anteromedial portal. When you make this anteromedial portal or any other portal, should that be a horizontal or vertical cut? There are a lot of evidence to say that horizontal cuts are very cosmetic, and once you heal, so you cannot figure it out. But on the other hand, especially for beginners, when you make a portal slightly higher or lower, you cannot extend it, you have to make additional portal. So in my opinion, earlier on in your beginning stage of your career, you make a vertical portal rather than horizontal portal. Also, when you make a horizontal portal, there is evidence to say that there is less damage to the nerve fibers around that area. The clipping of usual arthroscopy, left knee, AL portal viewing, and once you finish viewing, you make the medial portal. For that, you turn the foreobliquity towards the skin and make sure you avoid any veins and make the portal where you want to make. I always use a needle to know exactly where I want to go, whether it is going to be viewing portal or far medial portal. This has to be established such a way that you're above the medial meniscus. Also, you're not too close to the femoral condyle. If you are too close to the femoral condyle, when you make the drill hole for the femur, you can be excoriating the articular cartilage. The next slide. A lot of us make a third portal for superior medial portal for establishing the irrigation. So that means it's a 3-portal technique. Is 3-portal technique better than 2-portal technique? There is evidence to say that 2-portal technique is good enough, and there's less violation of VMO, and thereby the earlier return of quadriceps function, earlier rehabilitation, and faster return to normal activity. But however, to the beginners, I would say you continue to make a supromedial portal, so that is good for irrigation, good extension, good viewing. But however, later on you can switch to double portal technique. Accessory anteromedial portal, definitely there is evidence to say that is far better for an anatomically correct ACL tunnel, and lowering the femoral tunnel obliquity. You will learn to do that, but only issue is when you make the tunnel, make sure you are not too far medial or inferior and damage the medial meniscus or the femoral condyle. You can also make a superomedial portal for patellar surgery or reattachment of the tibial, distal tibial ACL avulsion fracture. How do you make the posterior portals? You have to know how to make posterior portals in order to do surgery as well as loose body removal, etc. This left knee, you go to the posterior medial compartment between the ligament and the condyle, palpate, look at the light flashing across, and pass the needle. The needle can be passed such a way that you can reach from above down to the attachment of the PCL. This is necessary for PCL surgery. You can make two portals or one single portal. When it comes to posterolateral compartment, you come with your scope from the anterolateral IAM portal, and between the condyle and the ligament you go to the posterolateral compartment. Posterolateral compartment is much smaller than the posteromedial compartment, so you got to be careful, because you have on the lateral side lateral popliteal nerve, medial side you have the saphenous nerve. You have to avoid them. Pass the needle first, inflection 90 degrees, and just make a small slit in the skin, then use your hemostat to push all the important structures away, and then again you make a cut with your knife. Otherwise you can injure the important structures in the posteromedial or posterolateral corner. Posterior portal are necessary for PCL reconstruction, removal of loose bodies, synovectomies, synovial chondromatosis, repair of the tear in the posterior horn of the meniscus, which we will see now after some time. The tibial avulsion of PCL tibial avulsion of PCL attachment also can be repaired using these portals. When you make the portal, you never make the portal in extension or 30 degrees flexion. You have to flex the knee in 90 degrees, otherwise you are likely to damage the important structures. As an example, is actually June did the surgery just 2 days back. We thought we will show the example of surgery possible through the posteromedial portal. Right knee, posteromedial portal, the red tear of the medial meniscus being repaired. The relationship between the neural structures of arthroscopic posterior portals, it depends on the positioning of the knee. You never make the portal in 30 degrees flexion, only in 90 degrees flexion can you achieve this. The relationship of the infrapatellar branches of the saphenous nerve to arthroscopic portals and incision for anterocruciate ligament surgery. The anatomical studies recommend that incision across the anterior aspect of the knee must be made with the knee inflection. The nerve was actually found within 2 centimeters of the medial border of the patellar ligament. So when you make far medial portal or accessory medial portal, you make sure you do not divide any of the nerve fibers. What about the popliteal artery? When you make the posterior portal or surgery, you always have a look at your axial section of the knee MRI and find out where exactly the popliteal artery is. The popliteal artery 94% of the time is on the lateral side, just lateral to the central axis. So you've got to be very careful when you operate from the posterolateral portal. What about transseptal portal? This is a portal whereby you make a division of the septum which divides the posteromedial to the posterolateral compartment and go right through. You always go from the posterolateral compartment to the posteromedial because posterolateral compartment is much smaller. This is useful for synovectomy and arthrolysis of the posterior side when you want to do additional lysis and PCL reconstruction. Very often when you do synovectomy for rheumatoid arthritis, when you are fiddling around posteriorly, inadvertently you have made transseptal portal. It's not very difficult to make, provided that you stick to this principle. The take-home message, therefore, is as a beginners, it's much better to have establish a vertical incision. Anteromedial portal, you find out what actual surgery you're going to do, pass the needle, and make sure you don't violate the articular cartilage, and then establish it as necessary. And you can make the accessory portal as many as possible whenever necessary. And 90 degrees reflection is the most safe position in which you can establish posterior or transseptal defect. Thank you.